Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professions, skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, costs of care, and the ABIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institution. I am Arjun Gupta, the Teaching Value in Healthcare Learning Network Fellow this year, and I will be moderating today's webinar. We are very excited to be featuring Dr. Arif Kamal today. Dr. Kamal is an Associate Professor of Medicine and Business Administration with Duke University's Palliative Care and Medical Oncology program. He has implemented and managed the Palliative Care program over at Duke for a few years now. Welcome, Dr. Kamal, and thank you for joining us.
Thank you for having me.
So just before we get started, I wanted to mention one thing. When we talk about value in healthcare, we refer to patient outcomes per dollar spent. Too often, we think that palliative care improves value only by cost cutting, whether that be by reducing ER visits or ICU admissions near the end of life. But equally, if not more importantly, it improves patient outcomes that really matter to patients, by emphasizing the entire patient and family experience. I think that's the key part of the value of palliative care.
I agree. Much of the attention tends to naturally flow towards resource utilization and the outcomes related to that with specialty palliative care. But really, if you take a step back, palliative care is a philosophy of care that involves both primary clinicians, that being primary physicians, and specialists like cardiologists, oncologists, working together with specialists to really take a global view of the quality of life of patients with serious illnesses and their caregivers. So what that really means is that we identify persons who have a serious or life-threatening illness from the time of diagnosis moving forward, thinking about what are the outcomes that are of importance to them. And as it turns out, sometimes those are financial. For example, health systems and patients can share similar interests in out-of-pocket costs and issues that affect their sort of long-term financial health. But also, patients are interested in quality of life issues like pain and symptom management, planning for the future, that they get the right care at the right time as their trajectory through serious illness changes, and also that they get a sense that the health system is particularly focused on them and their caregivers as the unit of care. So in palliative care, we really think that the patient, their caregivers, loved ones, their community, and everything that surrounds them is really the entity that we should be taking care of simultaneously. And so what that means is that, clinical trial data to date, plus our experience, also shows that by adding an extra layer of support, which is the tagline we give to palliative care, that by adding an extra layer of support through a multidisciplinary team, that we're able to improve depression, anxiety, pain, several other symptoms, overall quality of life, functional status, potentially survival, which has been very important for the field of oncology, and now increasingly we're understanding in COPD and other fields the potential to improve survival, as well as also making sure that patients have higher levels of satisfaction, particularly near the end of life, and we're able to reduce the amount of suffering felt by caregivers, both during that sort of active phase of dealing with a serious illness, during the active phase of end-of-life care, and then ultimately after their loved one has passed.
Wonderful. So with that, Dr. Kamal, can you tell us about some of the initiatives that have been implemented at your institution for increasing palliative care capacity and how you managed to achieve that?
Certainly. So any discussion about palliative care integration into the care of serious illness patients really sort of starts with the workforce capacity that you mentioned. And the field of palliative care, both growing very quickly, but simultaneously realizing that its capacity to have a specialist in every corner of every health system, in every corner of every exam room where a serious illness person is being taken care of, is severely limited. Because really there's an argument that these aspects of care that focus on quality of life are foundational to the professionalism of everybody who practices medicine, nursing, social work, chaplaincy, pharmacy, and so on, so that we both identify the patients who need those foundational components and those whose situations, either medically, socially, emotionally, or psychologically, require that extra layer of support where a team needs to be added above and beyond that team that exists. Being an oncologist, it's pretty clear that we operate oncology in a team-wise fashion as well, that nobody questions the need for having somebody who has specific expertise in radiation or surgery. So in a similar sense, we would say that for palliative care, every clinician and patient needs to decide together in a patient-centered decision-making fashion, at which point are you to a place where having an extra specialist is going to be helpful, particularly because of the background. You know, with oncologists, we talk a lot about an analogy to diabetes management. So every oncologist is a primary care physician, and many subspecialists have backgrounds in primary care, internal medicine. And all of them know that in their practice, they may see patients, say they're a cardiologist, where they may see a patient where they're handling a valve issue, but the patient has very complex diabetes. Now, the cardiologist or the oncologist may choose to handle that diabetes on their own because they have the time, expertise, and interest to focus on that. But other times they may say, look, here's the time where an endocrinologist and that endocrinologist team, right, a diabetes education nurse and a nurse that's focused on making sure they have the right glucometer and so on, is involved, that certain patients rise to the level of complexity and time where it makes sense to have an endocrinologist involved. Now, that says at the same time that most patients with diabetes do not need an endocrinologist to manage their diabetes. But for every individual clinician, patient, and condition or situation they're in, there becomes a line where it becomes pretty obvious that having others involved will be helpful. So here at Duke, we've taken that approach to say that we need to both simultaneously build the capacity of our colleagues outside of palliative care to provide foundational palliative care elements in the care they provide, while simultaneously increasing the infrastructure for our specialty palliative care services. And there's essentially three places where specialty palliative care services can touch the lives of patients with serious illness. The first is inpatient, naturally. Second is outpatient in the walls of our clinics, and third would be at home. So in the inpatient setting, we've developed a process to make sure that all patients with cancer admitted to our services are provided access to a specialist in palliative care. And that's recognizing that most patients with cancer, for example, admitted to the hospital, do have more of a palliative need than they do a curative or chemotherapy need, with some notable exceptions. And so we have what's called a co-rounding service. So every patient admitted to our inpatient oncology service is co-rounded, meaning simultaneously rounded upon by two attendings. The first is the oncologist, the second is a palliative care attending, which means that there is an automatic collaborative approach to their care where the oncologist will direct, well, here's the clinical trial they're on, here's the side effects we would expect from this interventional agent, where the palliative care folks can provide some context to, I wonder if we could try something new for their nausea. I wonder if the patient has a good sense of what they could expect from a phase 1 clinical trial, for example. Simultaneously, in that co-rounding service, we find that there's great benefit to the learners on the service as well, because they get input from both sides in terms of how do we talk about prognostic uncertainty. For example, in a time where there's great new therapies in oncology, for example, how do we both cheerlead the potential benefits of those therapies while also being able to, in a very compassionate way, talk about what if you're not the person that responded like in the clinical trial. So we found from that process that really bringing those teams together early on and really demonstrating to patients that palliative care and oncology integration are not separate things, and in fact we work together and travel together and take care of patients together, has been a really wonderful cultural change for our institution. And downstream, we found that our inpatient rounding service has gone from one of the least recommended intern services to now one of the most highly ranked intern services. They find great teaching on that service. In addition, we found that our nurses love this because they get to feel a part of the care that those cancer patients receive. On the outpatient side, we've now instituted sort of suggestions or reminders for patients who we believe should receive palliative care services. Now, that's different than a true trigger, because the concern has always been that oncologists love suggestions, but very few physicians like being told 100% of the time what to do. In fact, a lot of the reason that we come into medical practice is to have a certain amount of autonomy, and we want to respect that in all aspects of healthcare, but particularly for patients with whom they've had long-term relationships with and have developed that level of rapport. So what we've done is said, based on some criteria that we've agreed upon, let's have the nurses help sort of pen the orders in our electronic medical record. So essentially put the order there, but ultimately allow the oncologist to sign the yes or no. So it eliminates that sort of I forgot or it wasn't top of mind. So it helps the oncologist think about, oh, okay, well, this may be exactly the right person, but they may say, but they've got pain and I'm handling that. And maybe in the future that may be necessary. And so we've been able to sort of essentially put some cultural norms around the practice for referral to palliative care. And then lastly, on the home-based side, this is really sort of where a lot of programs are now going towards, understanding that many patients with serious illness are not able to travel, and so home-based care is important to them. And so we have, within the structure of our ACO, our Accountable Care Organization, both the infrastructure to identify patients who could benefit from palliative care in multiple different sort of analytical ways, and then are now using a combination of apps to reach out to those patients and their caregivers to help them learn about palliative care, and then also give them sort of just-in-time services so we can send nurses and nurse practitioners and social workers to their homes to provide what is truly very much upstream to hospice-type care. And many of these patients aren't anywhere near hospice, but what we've heard time and time again, both at Duke but across the country, is hospice is such a wonderful thing. Why can't patients receive that type of care, which means home-based care that's multidisciplinary, that focuses on quality of life, long before they are ready to die? And so those are the three places we've been trying to innovate here at Duke.
Wonderful. And so with all this information, Dr. Kamal, Duke probably had a lot of resources and a lot of institutional backing for this, but how does a smaller institution sort of triage these and decide which one to go with first?
Yes, it's a wonderful question, particularly because I started by saying that we have a workforce issue. So even if you were a large or medium-sized institution, it doesn't mean that particularly that workforce may be readily available to you. I think a lot of it has to do with understanding that when you've seen one palliative care program, you've seen one palliative care program. That the more you go around the country and you see how people do this, you realize that the variation in who they see and how they approach it within the culture of their institution is a hallmark of good implementation. That the variation in many ways is actually welcomed, because in a small hospital, they may find, for example, that they've got great buy-in from the cardiologist, but not the oncologist. And so in sort of an implementation, dissemination, adoption model, you want the early adopters. You absolutely do. And so our recommendation is, go find the early adopters and start there. And so if that's on the inpatient side with the hospital, it's fantastic. But that's on the outpatient side with heart failure specialists and the cardiology group, that's where you should start. And palliative care as a philosophy is really a movement. The point is not to change the entire culture of the entire organization when you first begin. It's really to start at a place and build from there. And what happens is that then palliative care goes from being kind of a new, cool thing that somebody's doing over here to really culturally being the norm of the institution. Then you realize that suddenly the cardiologists go, well, why, that's so cool what the oncologist is doing. We want to do more of that, and so on and so forth. There's a teaching back and forth. So I would say start at a place where you have champions, have a critical mass of patients, and you have buy-in, and then move out from there.
Perfect. And then I think you touched a little upon this already, but what is the exact role of the interprofessional team to make palliative care a success? I mean, you'd mentioned pharmacists, nurses. Is there anyone else, social workers, case managers? How can we engage that community to make palliative care a success?
Yeah, so let me make sort of a definitional difference here. So if you're delivering palliative care by using just physicians, we call that palliative medicine, right? Because that's what it is. Palliative care very explicitly uses the term palliative care with the term care as opposed to medicine, because you have to leverage the expertise and attention and resources that are brought to bear by, social work, nursing, chaplaincy, and so on. The National Quality Forum, in combination with the National Consensus Project for Palliative Care, has identified that a core palliative care team is consistent of 4 parts, which is the physician, nurse practitioner or advanced practice nurse or clinical nurse specialist, plus a pharmacist, plus a social worker and a chaplain with an option of having a pharmacist. And recent data shows that less than half of palliative care teams in the country are able to actually put those forth together. So when you think about how complex patient needs are, all the sources of distress, you realize that you really do have to get past just the medical components of their care into these other aspects. And physicians, frankly, as great as we may think we are, do not receive that type of training. And so we have to lean heavily on our other clinicians on our team. So it's very important to have a team, and very important when an organization is thinking about building a palliative care program, that they're, even if year 1 and 2 don't start with the full complement of the team, that they do have a roadmap in mind where the full team is brought in the picture.
Dr. Kamal, thank you so much for sharing your work and insights with us. We wish you all the best. We'll be posting some of the articles that you'd sent in our learning network as well. And that's all the time we have today.
Okay, thank you for having me.